what's it like being a critical care NP? It is the most challenging thing I've ever done in my life. This is a question from a tribe member who I believe is a current ICU nurse and maybe is just now getting some exposure to what critical care nurse practitioners are and what we do. I am an acute care nurse practitioner. I work in several different ICU settings. And you want to know what it's like to be a critical care nurse practitioner. I'll take you through a typical day. How's that? We work 12-hour shifts in the facility I work in. So the first hour is getting sign out from the previous shift. You get sign out on the entire ICU unit. So all of your ICU patients that are in the ICU, you get sign out on them. It's not the same as a bedside nursing sign out. It's a little bit more generalized, but then also detailed depending on the acuity level of the patients. That can take anywhere from a half hour to 45 minutes depending on the census and acuity level and how large your ICU is, to tell you the truth. Usually within the next hour, I'm researching all of my patients and I'm doing it in order of severity. I need to see the sickest patients first. Now, you got to understand that none of this happens in a vacuum. The only thing no, I can't even say that. All of the things that I'm sharing with you, they happen sometimes at the same time. There have been many times where we've done sign out in the ICU, at the bedside, or on the run because of a code, because of a declining patient condition, because of an admission. So while it would be great to live in a bubble and you sit in a quiet room for 45 minutes and talk about patient assignments and census, yeah, we don't live in a vacuum. So after you've gotten whatever sign out you can get, you're up on the floors and I'm looking up my patients. I'm looking up lab values, radiologic tests, x-rays, CT scans, results on tests that I needed to know. If it's my first day coming on, I need to look at what they came in with. I need to look at lab values, ABGs, what's normal, what's abnormal, what's the treatment plan, what are we going over, what's the goals for yesterday versus today, how long have they been in the ICU, what is their discharge planning, are we discharging them, transferring them out of the ICU, are they going to another facility, are they ready for the step down, are they ready for the regular floor, Then you're talking about the actual acuity level of the patient. Who's crashing and who's stable? Who needs the most attention and who can I get to last? And that quite honestly sets the tone for the day. The acuity level of the census and the acuity level of each individual patient. How many empty beds do I have? Do I have 2 patients coming? Do I have 4 patients coming? Am I on my own or do I have another APP? Do I have a resident? Do I have a student of some sort? Throw into the mix what kind of procedures are needing to be done. Is somebody needing a central line? Is somebody needing an arterial line? What's the complexity involved in that procedure? What's going on with their diagnoses? Before I stick them with a needle, I need to do some surveillance to figure out what the best choice is. Constantly reiterating and readdressing what the severity level and the acuity level is of every patient, because this is the ICU. Things change drastically at the drop of a hat. You could be in the middle of doing 2 things and all of a sudden somebody crashes and codes, or there's a code out on the floor. Because in my world, depending on which ICU you are assigned to, it is your job to answer and respond to the codes. You and another physician. But what happens if there's 2 codes? What happens if there's 3 codes at the same time? Yeah, that's actually happened. There's 3 codes at the same time, then you're going to have to figure out where you're going first. Who can you call for help? And are you running a code on your own until a physician gets there, or are you the only one that can do it? Yes, that happens. Will you have to do that, during your first months or years as an NP? Hopefully not. But it can happen. It's kind of like when you're in the bedside. Maybe you don't want to be charge nurse in the first 6 months of your job, but sometimes it happens. In the middle of all that, after I have assessed I've surveyed all my patients, and did I do procedures or not, the next step is to figure out who's seeing who. Am I by myself? Is it just me and the physician? How many patients am I actually going to write a note on versus how many patients am I in charge of? And that varies day by day. I don't want to give you a number because everybody's number is different, but it can be anywhere from 3 patients to an entire ICU, and that's just the reality of the game. You will not be efficient enough to be able to handle the whole ICU when you first start. It'll take several years for you to get up to that speed, and quite honestly, you never should, because you're an advanced practice provider. You are not the intensivist. So you shouldn't be required to do that, but we all have to pitch in where we can. Usually around that time is then you have multidisciplinary rounds, and that is rounding on every single patient with the team. That's you as well as everybody that is in charge of the care of every single patient, from the bedside nurse all the way up to the physician, the intensivist. And in the middle of that is all the ancillary staff, including the pharmacy department, your physical therapy, occupational therapy, dietary, case management, and anyone else that is partaking or involved that can be there at that time. The multidisciplinary round approach has been shown time and time again to improve outcomes and to shorten ICU stay and to improve communication. So we adhere to it as best we can. Those can last upwards of an hour to 2 or 3 hours, depending on acuity level, depending on number of patients, blah, 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 blah. Then after the morning's over, you regroup, you reassess. The patients that were stable, are they still stable? The patients that were crashing, are they still crashing? And did you get any admissions or admissions, transfers, or discharges in those first several hours of your shift? Usually that's around hour 4, 5, or 6, depending on how the day goes. Now remember, just like the bedside nursing role, you're going to get admissions, transfers, and discharges throughout the whole day. I'm also going to have to answer codes throughout the whole day. From then on, it's a matter of trying to get your documentation done. You have to write a progress note, an H&P, a transfer summary, a discharge summary, or maybe even a death summary if you have had a patient who has passed on your unit. If you're in charge of caring for that patient, whether it be a code that did not go the way that you wanted it to, or if it was someone who was comfort measures only. In my state where I practice, I actually pronounce the patient, I can sign the death certificate, and I do the death summary. That can occupy upwards of an hour of my day, depending on the length of time, severity, and complexity of that patient scenario. Somewhere in the middle of all that, pretty sure I'm going to be doing a couple more procedures depending on how the flow goes. You know, am I going to have to put in a dialysis catheter? Am I going to have to intubate someone who's crashing? Am I extubating someone who has been successfully weaned? Am I worried about, the condition of certain patients and what's going on? Someone having an active MI. What am I doing? How many patients am I caring for? How many notes am I writing? And that literally is the remainder of my day, is to delineate the continuum of care however that happens. If I intubate someone, then I'm in charge of making sure that the tube goes in the right place. I got to get a chest x-ray. I got to write the orders for the initial vent settings. I got to get an ABG. Then I have to talk with the respiratory therapist, the nurse, as well as the physician for what the plan of attack is for that particular intervention only. That's one thing. Then what if I did a central line or I did an arterial line? I got to confirm placement. I got to make sure that that's functioning. Dialysis catheters. New admissions. Am I doing the H&P? If I'm doing an H&P, did they come from a outside facility that showed up with a bunch of paperwork that's the size of a Bible, or is it an electronic medical record? How much investigating do I have to do? Do you have family members? In the midst of all that, you're going to have family meetings with patients that you're in charge of, or you're going to be part of family meetings that are within the ICU. I do a lot of family meetings, a lot of teaching. In the middle of all that, we are a teaching hospital, so we will have bedside education rounds, whether during multidisciplinary rounds or afterwards. I'm always teaching something to somebody, whether it's the new residents or residents that are on the unit, if it's going to be nurses on the unit, if it's going to be my colleagues or students on the unit. There's always teaching going on. Or I'm being the student and the intensivist is teaching me something new, or something that we're dealing with, a new diagnosis, a new treatment. From there, it's just a matter of putting out fires. And I'm imagining if you've spent any time in any part of the ICU, heck, in any part of the hospital, then you know that things change quickly and that the busyness of the unit it's a feast or famine kind of thing. There'll be days where you have a controlled day and I finished not only on time but early, and I can maybe take care of some other things. And then there's days where I haven't looked at a computer until the 10th hour of my 12-hour shift, or I haven't looked at a computer my entire 12-hour shift. And after I've worked my 12-hour shift, then I have to sit down and document my entire day on the 10 plus patients that I cared for, or more. That's just the way it works. So the level of acuity, the level of responsibility will change depending on where you're at. And it will also change with the level of experience you have. When you first start out, you should not be responsible for all the things that I have mentioned. As you grow into your role, you gain more and more experience, you gain more and more comfort, you also get more efficient at doing things. So you can imagine when you first started out as a bedside nurse, it took you forever to do a physical assessment. And then as the years have gone by, you could do a physical assessment in a fraction of the time. It's the same thing as a nurse practitioner. It's a developing role. It's something that ultimately you're going to get out of whatever you put into it.